When I am evaluating a patient, an MDS patient for transplant, I am thinking about two things. I'm thinking about their disease. Would their disease benefit from transplant? And then I'm thinking about them as an individual, independent of their disease. Would they benefit from a transplant? So of course, you first want to make sure that the disease is high risk enough, because there are some low risk diseases that you can just monitor or observe over time. And you don't necessarily need to subject that patient to all of the risks of a transplant. But if we do feel like this is a disease that really does need a transplant, then the next question is, okay, just because the disease benefits, does the patient benefit? And with that, we think about, so some of the traditional things that I think all transplanters think about are comorbidities, like what other medical problems do you have? We think about what we call performance status, which is a really oversimplified way of kind of thinking about how a patient functions during the day. And then what I am really trying to encourage more of us to think about is fitness in a really much more comprehensive way, because you can be very physically fit or cognitively fit and maybe have multiple comorbidities, and that shouldn't mean that you're not necessarily a transplant candidate. When I'm evaluating an older adult with MDS for transplant, I'm thinking of two things. I'm thinking of their disease. Do they have a disease that would benefit from transplant? So we know that some patients have low-risk disease that doesn't necessarily need to be submitted to all of the risks of a transplant, and we can just watch them for maybe many years. Or do they have a high-risk disease where they do need a transplant? And if that is the case, then moving on to the next thing, which is the patient themselves. Are they a person independent of their disease who would tolerate and benefit from a transplant? And the way that we answer that question is a lot more nuanced than how we used to answer that question. So we used to think simply about a patient's age, what medical problems they have, and that's really kind of it. And now we think really more comprehensively and holistically about a person's health and fitness, and that's where the geriatric assessment comes in. So that is a way for us to do basically a battery of testing looking at different domains of health. These include physical and functional health, emotional health, cognitive health, nutritional health, because we know that all of these areas of health matter and are very predictive of outcomes. And these things can be totally separate from a person's medical problems, meaning you can be very fit across these domains, even if you have, a few medical issues, and that should not necessarily preclude you from transplant. Graft versus host disease was and still to some degree remains kind of a major barrier to a successful transplant, and it's something that we really want to try to shield our patients against. In the last few years, there has been what you could call a revolution how we do prophylaxis for graft versus host disease. We're using a lot more of something called cyclophosphamide, or the term that we use is PTCy, or post-transplant cyclophosphamide. And we know that that is more effective than our traditional methods of preventing graft versus host disease. And I will say that is another advancement that has enabled safe transplant for older patients. Some of the most recent advances we have is just that we have more data to support the use of transplant in older patients, and that has come out really in the last 10 years, where we have very good justification based on studies and based on trials that even if we put, quote unquote, older adults 65 and older through transplant, they do benefit compared to non-transplant therapies. So I think just having the basis and the proof there has been kind of the most remarkable advancement. And then in general, as a field, we are getting better at what we call reduced intensity conditioning, which is the conditioning is what you give a patient right before transplant, right before you give them the stem cells. And traditionally that was using very, very high doses of chemoradiation that older patients simply could not tolerate. And we're getting better at reducing those doses and just making it more doable for older adults.